Thank you for everyone for joining us for the last session of the day. And before we get started with the PrEP in BC panel discussion, this morning I told Will he couldn't play his video because I wanted him to hold it until Saturday. But then we realized since then there's no way to play the video on Saturday. And so we really want to see this video. And so he's going to walk us through it. Thanks.
Thanks. So it's not actually the video I was going to show you, but it doesn't matter. So this one's going to kind of wake you up a little bit. And we've been making a couple of videos that we're going to show in clubs and bars. And the first one that I was going to show this morning was actually about trying to challenge PrEP stigma. This one is filmed in the basement toilets of one of East London's most infamous gay bars, Dalston Superstore. We filmed it at 7 a.m. in the morning because that's the only time we were allowed to go in. And it's never been shown publicly before, so this is the first time. You are a privileged crowd. And it's actually going to have its London premiere party on Friday when I go back. So, yeah, enjoy. It's about 2 minutes long, and I'd love to hear later on what you think of it.
I was very worried about what my friends would think if...
Good. Yeah, thank you. Will, thank you for that. I made a few videos at Health Initiative for Men while I was there, and I know how much fun those things can be to create, and that looks like it would have been a lot of fun to make. So this is our last session of the day. Thanks, everyone, for joining us. We're discussing PrEP in BC and how we get there. So as probably most of you in this room know, British Columbia, in particular Vancouver, has a history of HIV/AIDS innovation. It was here in 1996 that ARVs gained widespread acceptance as being the one big hope that we had at that time in the fight against HIV and AIDS. It's here that the first safe injection sites were piloted. It's here that we saw the Stop HIV pilot, now a provincial program, resulting in increased testing and treatment of HIV. But today, BC is lagging. In other well-resourced settings, we're seeing an uptake of combination prevention services, including PrEP, and that's largely due to research studies, publicly funded programs, and generics. Unfortunately, we're not seeing the same uptake here due to a number of obstacles. Our local gay men's health organization, Health Initiative for Men, has been advocating for PrEP since 2012, when we wrote one of the first position papers. Since then, HIM has offered workshops, education seminars, an information campaign, Get Prepped, and more recently, clinicians have started offering PrEP through the clinics on Davie Street. But access is still spotty and inconsistent for most gay men due to prohibitive costs and overwhelming demand on those clinicians that are prescribing. While we had hoped to have a provincial PrEP program launched by today, That has not yet come to fruition, despite our collective advocacy efforts. And in fact, just yesterday, our partners at the Pacific AIDS Network received this letter in response to a letter that they had written to the minister. And it's quite disappointing, particularly since you see that they're still citing cost as an issue. And not to mention they're citing outdated costs. And this is the executive director of drug intelligence. So we're disappointed with the response, obviously, but we are hopeful because despite this program, we've been told that a program is coming. A ministry rep told us last week at a PAN meeting by year's end, and our sources close to the Premier say it's imminent. However, we know that as every month that goes by, 10 to 15 new infections among gay men are identified in British Columbia. And so despite these rumors of a provincial program, we at CBRC and our partners at HIM and YouthCo plan to continue to pressure the government because we're also hearing that our pressure is working. This new government is listening, and so I want to commit to this group that the CBRC will not stop our advocacy until these needless obstacles to PrEP and other combination prevention techniques are removed and the tools are accessible for all. And with this in mind, we brought together 3 fellows who have been increasing access on the ground, not just talking about it, and we're so grateful to have them here. We have Dr. Mark Hull from the BC Centre for Excellence in HIV/AIDS. We have Dr. Darrell Tan from St. Michael's Hospital in Toronto, and Alex Smith, the founder of Davie Buyers Club. Gentlemen, welcome. I thought maybe... I thought maybe we'd just start right to left, and I know I gave you a brief bio of where you're from, but just tell us your association and sort of how PrEP is important to you.
Well, I think you've basically summarized why PrEP is important to us. I think I look at it from 2 ways. One, from an individual level, which initially when I got involved with PrEP is because there weren't really many clinicians prescribing, and I felt if I wasn't going to step up to the plate, who was going to step up to the plate? So definitely I think for some of the early adopters from 2012 onwards became very much a real issue for me. And I think from a public health standpoint, you've really highlighted the important issues. If we look at Vancouver, as you know, for the last 5 or 6 years, 70% of all our new diagnoses in Vancouver occur in MSM. And this is a number we really would like to see come down. I think the other issue that I think has become very clear to me is that there are ongoing and tight transmission networks that are happening in the city. If we look at young guys, less than 30, I think the most recent data suggests for people that are testing regularly, it's about a 10-month period from testing negative to positive. So transmission clearly is happening in the city. So what do? We have to look at all combination prevention strategies to get that under control. People should have all access to medication strategies or condoms or whatever they want to look at for HIV prevention. We've been very fortunate. We have a lot of buy-in from Vancouver Coastal Health and the HIM clinic. Myself, David Hall, we're hoping another clinician will join us as well, have started to offer a standalone PrEP clinic at HIM. So it's now going 3 days a week. And we're really looking at ways that we can access, improve access for people that do want to get onto it. And part of it is through some of the work that Alex has done.
Thanks, Mark. Darrell, do you want to tell us about that?
Sure, I'll be brief. I'm an infectious diseases doc. I have been an HIV care provider for several years, and after I finished my PhD in clinical epidemiology in Toronto, I kind of looked around. I had done my work in HIV and STI co-infections, which remain a big interest and a really important issue clinically and from a public health perspective. But when I kind of was launching my own kind of independent research program in Toronto right around the time that the PrEP studies were nearing completion. And I kind of looked around Canada and saw kind of nothing happening on this front, and it just didn't make any sense to me. In the clinic, we were seeing lots of young guys and other populations as well getting diagnosed with HIV day after day, week after week. In the HIV, in the STI clinic, we were seeing guys who were having lots of STIs, who were clearly at risk for HIV and not have access to a lot of other novel strategies. And it just seemed like there was this huge void in Canada in terms of any action on this front, and there needed to be some action. And so much like Mark just said, I just tried to get involved and contribute what I could. And I think there's still a long way to go, but hopefully we've made a bit of progress in the meantime.
Thanks, Darrell.
My name's Alex, and I'm a registered nurse. I used to live in Vancouver, where I worked at the Health Initiative for Men clinic doing HIV and STI testing. And it was through my experience at the clinic where I encountered patients on a daily basis asking me for PrEP, but with nothing to provide them, with the lack of a public program or most people lacking a Cadillac insurance policy. Unfortunately, that's where the conversation often started and ended. Some of these clients were later diagnosed with HIV, and I found it highly distressing that there would have been this prevention tool that would have been highly effective and acceptable for them. But because of lack of access, they seroconverted. So it was, very upsetting and frustrating for me, and I started looking for creative solutions to put PrEP into the hands of my patients who needed them. So I did some research and followed in the footsteps of leaders in the UK and Australia and implemented or created the Davie Buyers Club website, which is an educational resource which guides people how to first connect with primary care for a prescription, to see someone like Mark, and to fill the prescription for PrEP with an online pharmacy, importing it to a mailbox in the United States, picking it up and bringing it back to Canada every 3 months.
Sorry, I'm just feeling a little feedback coming from students.
And it's work that I've had some great support with, and I'm just happy to have happy that it's helped so many people.
Thanks, Alex. So for those of us in the know, we're aware that there are some various ways that people can get access to PrEP in Vancouver despite a publicly funded program. I'm wondering if you guys could walk us through some of those ways. I know some of you are directly involved in that.
So for Vancouver, while we wait for this imminent public program, we have a few ways that we can help people get onto PrEP. So the first question I usually ask people is, do they have a work plan insurance? And we look at data that's come from a Momentum study, and surprisingly, actually a very large number of people actually do have private insurance. And most insurance companies, other than the Pacific Blue Cross, will have a likelihood of covering PrEP depending on how good your plan is. And now that the generics are becoming available, I think actually it's even a little bit easier than it used to be. But I think, if I remember, a substantial proportion of Momentum, which is our MSM cohort, actually self-report private insurance. So usually that's the first step that we look at. Is it possible to use your private insurance to cover most of the cost of the medications? Before, when the cost was $950, $1,000 a month, if you were still paying 20% out of pocket, that was sometimes a barrier for a lot of people. But now that the cost is with generics, so $450, $470 a month, that becomes a much more affordable target. If they don't have private insurance and they are able to cross the US border, then we steer pretty much everybody else to the Davie Buyers Club as a way to get onto it. There have been some clinical trials through the primary care clinic spectrum. So they're doing a clinical trial looking at different strategies for PrEP. So a number of people have access through there. Up until this year, if you were covered through the NIHB, so the Non-Insured Health Benefits Plan for Indigenous individuals, you could get it through there. Now that it's switched over to coverage through the province, through the First Nations Health Authority, I'm not sure, people are grandfathered in, but I'm not sure actually if they're approving new PrEP referrals. And we've had a number of other novel sort of public health related targeted strategies. So we've looked at trying to offer PrEP to people where we know their partner has recently seroconverted in a high risk sort of network. So we've looked at that, and our estimates at the moment are there are probably about 700 or 800 people that we know about that are accessing PrEP. 450 or so look like it's through insurance, about 200 to 300 people through Davie Buyers Club, and a smattering through the other routes that I just described.
Mark, just a point of clarification before we talk about generics with Alex a little bit. So if there were somebody in the audience here today, or if we knew somebody, a friend who should be on PrEP or might be interested in that, what would that look like? Like, would it be just pick up the phone and call Health Initiative for Men and book an appointment? And are there other ways? It's my understanding there's a bit of a wait list. You're popular.
It's not just me, so I can't pretend I'm the only person there. So I think a lot depends on a few things. Do you have a family doctor or not? if you do have a family doctor, is your family doctor vaguely, first of all, A, gay-friendly, and B, aware of PrEP? If they're willing to look at it into you, the BCCFE website now has very clear PrEP guidelines to help starting clinicians get their patient onto PrEP. So you could, if you had a family doctor, guide them onto PrEP, and Darrell might talk about some of the research projects they've done to help you educate your family doctor about PrEP. The other option is, if you don't have a family doctor, or if your family doctor wants to refer you, yes, then you can go through the Health Initiative for Men, and then you might be assigned to one of the primary care doctors like David Hall, and I think now we have another person starting on Wednesdays as well, so you would get onto there. Or if you had a family doctor that wanted to refer, then obviously you would be referred to our clinic. And I think the list isn't that long for him, and we're trying to make, as I said, more spots available to really improve access. But yes, there are a number of ways. Anytime you show up at the HIM clinic, we would find a way to have you see somebody that could get you onto PrEP.
Great, thanks.
And I should actually add, we're working with the BCCDC, so they offer clinics for STI testing through Butte and HIM, and I think we're very, very close to having them come on board offering prescribing as well. So we're doing some final training and work with them, and they've been actually very enthusiastic to take it on. So I hope in the next 2 to 3 months we actually will have a significant increase in capability to have clinicians offering PrEP through the STI clinics as a direct entry port.
Great, thanks, Mark. Darrell, a lot of people got onto PrEP through studies, particularly so-called early adopters, and I know that you were one of the PIs in a number of those studies in Toronto. I remember as the study concluded, there was sort of a dilemma about you've got these folks on PrEP, and now where do they go if they can't afford it or they don't have insurance? I wonder if you can talk just a little bit about the limitations and also the opportunities of PrEP research.
Yeah, as a way, specifically as a way to get access to the medication. Yeah, so I think there's a lot of, okay, so first I want to clear up the misconception. It's very kind of you to say I was involved in a lot. I led one study, one small study, and by the way, if you're interested, we're presenting the final results from it tomorrow, but at this meeting. So, so yes, it is a way. So I'll try to frame my response, I guess, in a way that maybe gives a bit of everyone an understanding of the different ways in which one could potentially access PrEP through a clinical trial in general, and whether I think it's relevant to think about it this way because it's applicable to whether we're talking about PrEP as we know it today, which is TDF/FTC on a daily basis or on an on-demand basis. Or alternatively, there's a lot of research, as many people in the room may know, at future generations of PrEP products. There's clinical trials looking at injectable agents. There's already a vaginal ring that is under the regulatory approval process for heterosexual women. So a lot of these concepts will be applicable in the future as well. So, okay, there's a few different ways in which a PrEP access through a clinical trial could look. One way is that investigators themselves, researchers themselves say, hey, here's a need, we want to study this, let's do it. We use that model in Toronto. It's a lot of effort because if you're going to get access to the drug to run a study, you need to not only have funding to run your study, have personnel and all those things, but you need the drug itself. And how are you going to get the drug in an era when there's no other manufacturers of the drug but to go to the manufacturer themselves? So we approached Gilead, as did many other people around the world several years ago, and asked them to partner with us and give us drug. That's a whole process in and of itself. It took a long time, and there's lots of legal annoying issues that we had to deal with along the way. And ultimately, it's an agreement that you're entering into with a for-profit company to give you the drug, and there may be conditions that they will put around that. And as a result, although I wish that we could have guaranteed participants, volunteers in our clinical trial, access to the drug beyond the timeline of the clinical trial, that wasn't something that the other party agreed to, Gilead agreed to, and so we were left with a small pilot study of 1 year. And I think, so maybe some of the lessons there are, number one, we need investigators to get involved in running clinical trials in this field in the future. It's a challenging process, but it's also a really fun area. There's not enough HIV clinical researchers, I think, in this country. Mark and I often share our frustrations around that. We need more colleagues, and so we want to encourage people who are coming up through the ranks to think about this as a career path. Secondly, I think another lesson is that when you do this, you want to have those negotiations. You want to go to the bargaining table with a third party that's going to maybe provide a product with some negotiating points in hand, and asking for access to drug beyond the lifetime of the study is a basic tenet that we should always ask for. We can't force the other party to agree, but we can certainly try really hard. Of course, another way that one could access a drug through a clinical trial that's run by investigators would be that the investigators purchase the drug. That's probably only feasible if you can get a really good deal on it, such as perhaps through a generic manufacturer. And of course, in different parts of the world, that's exactly the model that has been used. For example, in Australia, some of the states have huge demo projects. We heard this morning about that approach being taken, for better or for worse, with the NHS in England. So that's another potential model that could be used. Again, though, we need people to step up to the plate and run those studies, because it is a lot of work. And then a third mechanism, of course, is that the manufacturer themselves design their own study. It's notable that in the whole PrEP field, if we define PrEP as daily Truvada, daily TDF-FTC, all of the studies that have formed the evidence base on which we know that intervention works have been run by and initiated by investigators. Okay, none of that was primarily funded by the manufacturer. They did donate drug. They have come up with the trial that Mark alluded to earlier, looking at TDF-FTC versus a new formulation called TAF/FTC, also known by the trade name Descovy. It's enrolling in a few sites in North America, including a couple in Canada. There's a lot that we could say about that as well. I just want to remember that that when people enter clinical trials like that you want to make sure that they're fully informed about what is being looked at in the study. That is not technically a study in which everyone is going to get free PrEP. That's a study in which half of the participants got randomly assigned to get PrEP as we know it, which is daily oral TDF-FTC. The other half was getting randomly assigned to get a related product that we did not know, we still do not know whether it works as PrEP or not. And unfortunately, there was a little bit of miscommunication around how that happened, such that some people were under the impression that I'm going to get free PrEP through this clinical trial period. That's not quite accurate, and we have to be very careful about that with studies. So anyway, those are just a bunch of comments around how one can access PrEP through a clinical trial, and I'll leave it there.
Thanks, Darrell. You mentioned Descovy. Mark, there are a couple of other trials in Vancouver as well, or at least they're about to go online. Can you talk to any of those?
I think there's only one upcoming study which has run into the same issues that Darrell has alluded to, which is regulatory hurdles and legal issues. So Troy Grennan, one of the main physicians at the BCCDC, the STI head program, and I have been working on another study which has derived its idea from work that's been done in France, in the IPAGAY study, and then in a project in Los Angeles, which is to say, if we look at other infections that can affect men's health, syphilis is one of the main other STIs that we see. And there have been a number of projects looking at using antibiotics either as post-exposure prophylaxis for syphilis, or actually now also looking at an antibiotic, a low-dose antibiotic for syphilis pre-exposure prophylaxis. And so we have funding to do a very small pilot study that will offer people Truvada for PrEP, for HIV PrEP, and they will be randomized to an antibiotic to see if people will tolerate it, if it's something that's acceptable to people to do, as a way actually to look at trying to decrease our syphilis numbers as well. So that study, I think, is almost through its regulatory hurdles. I think we got our final letter last week, so we're hoping that study will be up and running, by January or so. So then they'll get HIV PrEP, and then the study part will be looking at strategies to prevent syphilis.
And that's about 50 individuals, right,
50
Mark?
people, yeah.
And Descovy's done recruiting in Vancouver. Do we know how many they enrolled?
120 people.
Only 120. Okay, I thought it was more than that. So
No.
my numbers are off today. Alex, generics are increasingly an option for individuals who live close enough to the border to cross, and you've been largely responsible for that in Vancouver and other places. I know Ontario has also been working with Davie Buyers Club. Can you talk to us about some of the challenges and opportunities with generics?
Yeah, absolutely. There are many challenges that exist with access to imported generic PrEP. Essentially, the sort of Davie Buyers Club method, or the cross-border importation method, really can only serve people of sort of moderate to high means. It doesn't do anything to address the needs for PrEP for people who are high risk and low means. So that's because in order to follow this method, you need significant resources. So you need, as Will mentioned this morning, you need to have the money to pay for 3 months worth of PrEP up front. You need to have a credit card or some other means of payment. You need to be able to get to the border, which isn't as much of an issue in Vancouver because you can get there on the bus here, fortunately. But where I live currently in Calgary, that's a 3-hour drive. For people in Edmonton, that's a 6-hour drive. So there's transportation and practical and cost issues with that. I've heard from people who are not able to access this method because of a criminal record that prohibits them entry to the United States. Also, people for whom have immigration status requirements that do not allow them to leave Canada while they're in whatever process of their immigration. So yeah, also another big one is literacy in the English language. So unfortunately, my website currently and ones like it are only in English. And I've heard from people, inquiring generally, people from South Asian communities and Asian communities, some Middle Easterners, who have understandably a hard time and need some guidance to navigate this very complex process. And if you haven't been to my website just to see how complex it is, it's tricky. You need to navigate a health system crossing international borders, and to do so when English is not your first language is very, very difficult.
Thanks, Alex. We're hearing a lot of things coming out of Quebec and Ontario around a government-sponsored program, and I feel like there's a bit of education about that. Darrell, can you walk us through specifically Ontario's recent announcement?
Sure. Okay, so yes, there was a major announcement in Ontario at the end of September, and I think there's a big shout out that needs to go out to a lot of the community advocates that really pushed and fought for this to happen in Ontario, and we think it had an awful lot to do with this announcement coming through. We fortunately did have a ministry that I think was very much engaging with us in this whole process over the last couple of years, really, thinking about this issue and trying to get some of the research information, hear the voices of the community, and ultimately culminated in this announcement. So what was the announcement? The announcement was that Truvada, so the brand name product manufactured by Gilead, as well as the generic manufactured formulations of TDF FTC, were added to what's called in Ontario the public formulary, which in Ontario is called the ODB, Ontario Drug Benefit. That is not this, and so that has been, the shorthand for that has been that people have said, oh, it's now available publicly in Ontario. That's an accurate statement, but the details of it need some explication. So it's not the same as saying that it is free to any Ontarian. Okay, so although it is a public formulary, there are several mechanisms through which a resident of Ontario can get access to this public formulary, which includes TDF FTC now, as well as a whole bunch of other prescription medications. We can list what they are. So one of them is, if you are in the age category of people aged 65 or older, you are entitled to this drug, to the ODB formulary. A second mechanism is if you're on any form of social assistance, so really that amounts to ODSP, the main disability program in Ontario, Ontario Works, which is another social assistance mechanism, then you're entitled to the program as well. As of January 1st, the Liberal government, to much fanfare, is announcing something called OHIP Plus, through which individuals up to the age of 25 will have access to anything on ODB. That hasn't started yet, but it will include PrEP for young people, which is fantastic because so many of the new infections that we're seeing in the province continue to be among young people, particularly young GBMSM. And then, for everybody else, which is a huge chunk of the demographic to whom we think PrEP could be really, really useful, what you have to do is you have to get access to a program that's called Trillium. So what is Trillium? Trillium is just a mechanism that is available to people who aren't listed in any of the above categories to get access to the ODB formulary, but it's not free. You have to pay a deductible to get access to the Trillium program. You also have to do a bunch of paperwork, which may be opaque to many people. Fortunately, many service providers, social workers, folks at tons of the ASOs in town, pharmacies even right there on the ground in Ontario are very savvy with this and can walk clients through the process of applying for Trillium, but the paperwork is another kind of process and barrier. But how much? But fundamentally, when we're talking about money, you have to pay. You have to buy into the program, and the cost of that is scaled to your income, which sounds good, but effectively, your deductible could be as much as 4% of your total household income. Okay, so that means that many people who have a decent salary may, when they look into this process, find that their Trillium deductible would actually be more than the cost that they would be paying if they were going to purchase PrEP out of pocket, now that it's available in Ontario at a list price of around $230 a month. So for many people, the cost of this publicly funded product is still $230 a month or less than that.
Thank you. We're going to leave lots of time for questions. I also see a few people fanning themselves. It's not lost on us. It is warm in here. I've asked them, literally, I just texted Michael to ask them to pump some cold air into the room if they can, so help may be on the way. No, it's warm in here. Let's start with you, Alex. I want to ask each of you, what do you think the biggest barrier to PrEP access is and how we can overcome it?
That's a great question. So from my experience as a nurse in the clinic and online with the Davie Buyers Club, the biggest issue that I encounter with my patients and website participants is cost. We need a publicly funded program. So ideally that would be free for all those who need it, but if it ends up being like Ontario where it's scaled, I will take it. Anything is better than what we have currently. So yeah, that is the number one concern that, or the number one barrier that I encounter, like I said, in my practice. And the whole point of my website is trying to be to skirt that issue or to address that issue for those who are able to. So yeah, that's really number one for me. I know that there are a number of other issues, but I'll let these gentlemen talk.
Okay, so there's so many things. But
you can have a couple, Darrell.
I'll just say one, and then we'll see what Mark says, and then maybe I'll add more afterwards. So what is the biggest barrier? And I'll say that it's not as concrete as what Alex just said, but I think one of the biggest barriers that we have faced and probably continue to face right now in the whole country around PrEP access is a lack of leadership. And when I say that, I'm really speaking about the absence, the very conspicuous absence right to this day, of action, of social marketing campaigns, of leadership in kind of trying to advance this effective intervention that we've known about for 6-7 years now, by public health authorities, folks who are, this is a public health issue. HIV has been one of the greatest HIV public health crises of our time, if not the biggest one of our generation. And yet, unfortunately, public health organizations across the country at provincial levels, at national levels, have not really been very forthcoming in taking a stand, talking about it, whether they're going to advance it or not, just even raising awareness and commenting on what its role could be, should be. That's not been happening. A little anecdote that's related to it that Mark and I feel very passionate about, I think, is that we've been working on and are soon to have a major announcement about clinical guidelines on PrEP in Canada. And very early on in the process, we engaged a lot of different organizations to try to get involved. First of all, I should even say that we embarked upon the initiative because no one else was doing it, and there was a conspicuous lack of guidance for Canadian providers on how to get involved in providing, in prescribing or supporting this intervention. And so that's why we launched the process. We engaged lots of different organizations. Many of them have endorsed the guideline that is due to come out very soon. We also approached the Public Health Agency of Canada, which part of me naively had thought, oh, of course, PHAC would come out and be trying to lead this. PHAC has published and continues to update STI guidelines in this country. Unfortunately, there wasn't a lot of engagement. The response had been, we don't do that, we don't endorse guidelines. I think another common refrain from many public health authorities has been, we can't comment on that, we can't support that. Our hands are tied because, at least prior to last winter, PrEP did not have regulatory approval in this country, and therefore, we cannot talk about it for logistical reasons. That might be the rationale that's advanced. I don't buy it because there's a lot of other examples of things that do not have public or regulatory approval in this country. PEP is a great, conspicuous, and very obvious example that public health units often do talk about. So why is there a double standard there? Analogously, harm reduction interventions of all sorts, needle and syringe exchange programs, safer injection sites are things, naloxone are things that many public health units have actually taken some steps to try to directly address. And we unfortunately live in a country where drug use is criminalized. So to say that we can't comment on PrEP, we can't do anything about it because there isn't regulatory approval for such a long time is just an argument that I don't buy, and unfortunately it's led to, well, for better or for worse, it's led to a lot of grassroots efforts from community organizations, from those of us who are involved like on the clinical side or the service provision side to get up and do some really innovative things like form the Davie Buyers Club. But I think if there were high-level engagement, leadership on this issue, then we would probably be a lot further ahead across this country today, now in 2017 than we are right now.
Thanks. How about you, Mark?
I think those are very critical things. Lack of drug, which I think we can talk about in a little bit more detail. For sure, an abject lack of leadership, but I think you're too optimistic for PHAC. I've written PHAC off years ago, as you well know. I think they're the most completely useless organization in the country, and don't get me started about them.
They did fund today, just so we're clear.
But I think clinically, one of the barriers that we run into at HIM is, and Darrell has done work on this as well, is I think honestly, even at the community level, the conversation is still very spotty in terms of what people know and what are willing to talk about. I think people objectively are unable sometimes to classify themselves as being at risk for HIV, where this would actually be something they saw as benefiting themselves. So I think part of the conversation is, as a service providing organization, whereas frontline nurses, as Cassie, who's in the audience, might say, is a lot of people don't see themselves at risk, even though objectively we can look at their STI history and say, you are high risk, you need something like PrEP. But they don't see themselves in that conversation. And I've done a lot of work with the BC CDC. We've traveled around the province. And I think the conversation that we're having in Vancouver now is light years ahead of the conversation that's happening in many communities outside of Vancouver, where people are not asking about access. They're like, what are you talking about when you're talking about PrEP? You've come to Kelowna, you're in Victoria, you're in Prince George, and this is even the first level, is just even hearing about things. So I think, what we're talking about in Vancouver is very, very different to some of the conversations that are happening around the province. And we shouldn't forget that we need still some of that community level education and some of that community buy-in in terms of what PrEP means. For me, I think about it this way. You have a medication here that is almost 100%. I would actually go so far in people who are taking it regularly to say 100% protective against an incurable and possibly fatal disease. If this was a pill for cancer, I think we would have had it funded several years ago, and I think there would be a very, very different conversation at the community level. So, I really think we need to change people's mind. Why wouldn't you take PrEP? I can't think of any reason why, if you're a sexually active individual where you could be at risk for HIV, why this would not be something that you'd want to endorse, and why are people not talking about it with their friends? Why is it a hidden conversation? So oftentimes people will come to me and say, I only heard about it because now I found out my friend has been on it for 2 years, and this is the first time I've heard about it. So I really think at a community level, we have to have more open and frank conversations about the benefits of PrEP.
I want to unpack some of those layers. I think we need to talk about community awareness, healthcare provider awareness, funder awareness, but I thought maybe we could talk. I know each of you are involved in educating other healthcare providers in some way, shape, or form around PrEP, whether or not it be through formal. I think Darrell, you were working on a CME course at some point, or Mark, you were going out into some of the regions. Can you talk a little bit about your education to others?
Sure. So the access puzzle clearly involves a lot of different steps. It's not just about the drug, although that's a pivotal part of it. Another key part is the person's own awareness, identifying themselves as user. Even if you had the drug and you had the potential user, you need to have someone who's going to be able to provide that. So we need providers to be addressed, or the lack of providers to be addressed. And we need to think about the fact that providers need to be not only knowledgeable, but they also have to have the savvy. They have to have the know-how. They have to have the connection with people, so that people, gay men in particular, or queer people in general, will feel comfortable going to them. There's lots of people who are very well-meaning, but if they are not going to be able to engage with gay guys on a level that gay guys are going to be able to talk to them about their sex lives with, again, it's a non-starter. So one thing that we're doing, or two things that we've been doing to try to tackle that are, number one, is develop these guidelines. So we, a couple of years ago now, got a CIHR grant to start a process of developing evidence-based guidelines on PrEP as well as PEP. And long story short, the end is in sight. Around World AIDS Day, we anticipate that this will be published in the Canadian Medical Association Journal, which has a huge readership. We're very excited about that. So look out for that, and we'll be trying to promote it actively. But you can't just kind of put a product out there and expect people to read it. You got to kind of do things to actively engage people in with it. So one thing that we've designed as an implementation research project, but is really kind of an action-oriented kind of research project, is in Toronto to start a pilot project, which is a neat little idea that we came up with, I hope. The idea is to really engage the fact that up to this point, a lot of the impetus for starting PrEP has really come from people themselves, right? Gay guys in particular, are really connected. We talk to each other, we go online, we learn about what's happening in other parts of the world. So a lot of the time the conversation starts with a guy, a person, going into their provider or a healthcare provider saying, hey, I'm interested in PrEP. And then sometimes they get a response like, what's that? Or I can't do that, or that sounds crazy, or I'll just refer you somewhere else. So what are we going to do about that? Well, we designed a little project which we called Patient-Initiated CME, Continuing Medical Education. So the funny acronym that spells is PIC ME. It doesn't really mean anything. It just kind of sounds cute. And the idea is that in that moment where the person is having a conversation with the provider and there's some sort of barrier that's put up by the provider because of their lack of awareness or knowledge on this, we've kind of primed that person already through a little card that a lot of our CBO partners in Toronto are actively giving out right now, that says, on the one side, there's some information for the person himself. There's a little module that he can go online and kind of do to just learn a little bit more about PrEP and think about how they're going to have this conversation with the provider, kind of coaches them a little bit on how to have some tough conversations maybe with their provider. And there's a research component. There's a short survey that they fill out as well, accessed with a code number. But when they see that provider and the doctor says, I don't know what that is, that sounds crazy, what's PrEP, I don't know what you're talking about, they say, here. And they take that same card. There's also an electronic version. If they have it on their phone, they could show it to the provider. And on the reverse of that card, there's some information for the physician. It says, how to prescribe PrEP, information for physicians. And it says, hey, PrEP is this effective, Health Canada approved intervention. It works really, really well. It's safe and effective, well tolerated. And here is an online module, which is what you're alluding to, Jody, that we've also created. We have some medical education kind of experts within our team who helped create a little module online that coaches them on how to deliver PrEP in approximately 1 hour. It's based on the content of the evidence-based guidelines. They get credit for it, so we got approval from the Canadian College of Family Physicians to get a couple of credits, which is a good thing for physicians. It's a motivator because docs have to, announce how many credits they get every year. And it also has a little survey attached to it, so we'll learn a little bit, hopefully, if the providers are willing to do that. And we hope that the motivation of a patient coming to you as a provider saying, I need this intervention, and here's what you need, and showing them a resource that we hope has some legitimacy because of the credits, because of the evidence-based guidelines, because of the Health Canada approval, will be motivation enough for some of those providers to actually be willing to say, okay, I'll go do this module, come back in a couple of weeks, and maybe we can get started. And the last comment is that there's a little safety valve in there. We recognize that some folks are just not going to have a family doctor, or not going to be comfortable going to their family doctor, or the whole thing just might not work. They try, but it doesn't work. So the safety valve is that we actually partnered with Toronto Public Health, trying to get public health units involved, in training a bunch of nurses at some of the sexual health clinics in town on a medical directive that we developed with the medical leads of the sexual health clinics to have the nurses actually deliver PrEP under a medical directive. And we're very excited that within the first 3 weeks or so of the project launching in Toronto, we've so far had a little bit of uptake. I think there's a small handful of patients that have already presented to Toronto Public Health clinics and are getting it now through nurses.
Thanks, Darrell. Alex or Mark, do you want to talk about educating other healthcare professionals?
I actually had a question for Mark, if that's okay. I know that the Centre for Excellence has been very supportive of physicians around the province with regards to antiretroviral treatment for HIV-positive people. Do you see the CFE, expanding that 24-hour call line, support line, where physicians can speak to an HIV physician or an HIV pharmacist? Do you see the CFE taking that on, or do you see benefit in such a program?
Yeah, I think we're heading that way. So the CFE has had its own guidelines for PrEP for physicians for a couple of years now. We've adopted a very similar idea as what Darrell has just discussed in terms of expanding knowledge. So I think I'm going to steal Sylvia gave me his thunder. She's probably not going to be very happy with me to say this, so nobody repeat this comment outside of this room. But she is going to be announcing on Monday that there's going to be a new online module for both PEP and PrEP with CME sort of accreditation that will be launched on the CFE website, so physicians can learn about NPEP and PrEP at the same time. And I think as part of that, as we expand our program across the province for PEP, the hotline will allow physicians to call about PEP and probably take PrEP calls at the same time. We've done some work with the Vancouver Coastal, so we've done a number of physician workshops and physician education workshops to try and improve GP level knowledge. We're doing the same thing with BCCDC physicians, which is why I think they'll start on. We've done the same thing in Victoria. We've offered the same service to other health authorities with very limited enthusiasm so far for uptake. But we hope that as the momentum goes forward, we'll have a mechanism to do sort of training workshops with people around the province. I think Darrell's idea of nursing-led PrEP is very fascinating. I know Cassie in the audience is very interested in this. We've had some conversations with VCH, and I think we're looking at ways to involve nurses to at least do some of the follow-up, if not the initial prescribing initially, just really to improve capacity and improve access. I think if we have access through him and through BCCDC, that's going to be a large group of our very at-risk MSM able to access at a very low barrier PrEP services, and if we can get other GPs on board as well, that's just an extra benefit.
Thanks. I want to close, before we open up to questions, around thinking about community-level access, or access for not just gay men, but other populations as well. So we've heard that PrEP is so white. We've heard that we're not seeing uptake among trans communities, despite the fact that they were one of the original populations studied in IPREX. We know that Indigenous men are not taking up PrEP, despite the fact that many of them could have it covered through the health insurance benefits. So, and if this is for each of you, what can we do as healthcare providers, as people who work in CBOs, as activists, to increase the uptake of PrEP, not just among cis white men, but all vulnerable populations?
I think reaching out to communities of color and asking how we can support them and to champion those leaders in those communities. I don't think that the solution is going to come from us. I think it's going to come from the community. So I think, yeah, asking and empowering is the way to go.
Yeah, I completely agree with that. I'll just comment briefly that so we've started to think about asking. Not started to think about. We've engaged in some projects in collaboration with some community partners, for example, in Toronto, in the ACB community, which is one of the priority populations in Ontario at risk for HIV. So we've been doing a study for like a year and a half to kind of understand some of the knowledge, feasibility, acceptability, et cetera, of PrEP in ACB heterosexual men and women in Toronto. We have some funding application. We have a small funding application in to do something similar in specifically in people of Chinese descent in Toronto, because actually the Ontario numbers suggest that new diagnoses in East and Southeast Asian populations is actually slowly creeping upwards, actually, in the last few years, which is of concern. But I think, so hopefully we'll learn something from that about what communities themselves think needs to be done. But I guess two caveats to that. One is that I think we have to be cognizant of the fact that there's a lot of structural and systemic reasons that the engagement has been poor to begin with, right? So there's a lot of, there's like, centuries worth of history that explain why in a country like Canada there's a lot of lack of trust of the establishment, no matter what you look like as a person, no matter what identities you bring to the table as an individual, as communities, there's a lot of mistrust, and it's well grounded. It's founded on real facts, things that historically have happened that we have to own up to. And I don't pretend to have solutions to them. I think they're massive, huge challenges. The second thing is I think I want to recognize that, it's all nice to say that, oh, we're going to partner with Black Cap in Toronto, and we're going to partner with all the other African organizations in Toronto on these projects. We also have to recognize that those organizations are already stretched thin, that the funding to them has always been in a very tenuous situation, and so their capacity to really meaningfully engage logistically is really stretched as well. And I think there's lots of kind of community advocacy that can be done around making sure that those organizations are able to be well funded enough to engage in these things to address the root causes of these problems.
Thanks. Mark, did you have anything you wanted to add? I wanted you to just go a little bit further into something you alluded to earlier, which is that there is a program. So if you wouldn't mind just discussing the targeted program briefly that exists in British Columbia, and even folks who are at risk are not, some are not taking prescriptions.
Yeah, I think it's been an interesting program. So when we first started applying to pharmacare for a provincial PrEP program, there was zero buy-in. And even today, the little gray men in Victoria have very little interest in funding a line funding item for PrEP. So no matter what politicians say, they didn't knock at the door with a check going, here's $5 million, put everybody on PrEP. So don't let anybody fool you into thinking that's the case. So it was a niche area, and really there was nothing we could do in various permutations of applications to pharmacare to get them to fund it. So start working with public health. The CFE announced an interim project, which we thought would hopefully at least provide some access to very high-risk individuals, which was a targeted program. So here we know, if we look at the province, as I mentioned already, we have very tight transmission networks. We can see very clearly that there are ongoing transmission clusters that people belong to. And so what we had worked with Vancouver Coastal initially, and now actually with VIHA on the island, and actually Interior Health as well, so not just Vancouver, if there's a cluster that's identified at time of partner care and partner notification, those individuals who are named as contacts as part of that cluster, if they test negative, are offered PrEP as an interim solution to having a provincial program. And so we say to people, oh, you have been named as a partner, your partner tested positive, you've tested negative, would you be interested in going on to PrEP? And what we found actually is the uptake has been quite low. And I think this says two things. One, I think it speaks to the fact that people still don't really identify themselves as being at risk. And my personal feeling about it as well is I don't think without there being a clear groundswell of normalization of PrEP in a community, that being offered PrEP in that way has actually been regarded as a benefit. I think it's not been something that people have said, oh, my friend's all doing, so I for sure want to get onto it. It's sort of been a bit avant-garde and out there. So I think, as we see more uptake, then we've seen, I think, over the last bit, I don't know, Misty, the recent numbers, but I think more recently we've had actually quite a lot of success in people now hearing about PrEP and saying, yeah, oh, you're offering me free PrEP for sure, I'm going to take it. But in the early days of the program, it was a bit of a hard sell, I think. And I don't know if the nurses here want to say anything more because they were the ones actually making the offer, but I think there was quite a bit of challenge in the beginning to get people to buy into that as an option.
I think that speaks to the work that we need to do on the community level in educating our peers. And the problem is it's a bit of a catch-22, or because we don't have a program yet. So if you create the demand, where do you refer people afterwards? You're setting up.
I think you have to create the demand because there's no pressure on the system otherwise to change. So I think there is demand. The more demand there is, the more we have to look at expanding access through HIM, the more we have to expand access through BCCD. Once that puts demands on our services, then it puts pressure on the higher-ups in terms of looking at what the voice is for public health in terms of influencing policy in Victoria. So I think you have to create demand. If you don't, this conversation goes nowhere. And actually, Darrell and I have talked about this. We have slightly different views a little bit. But I think in my clinic that I feel there's a phase shift in terms of what is the conversation in Vancouver. Like before, in the early years, it was a slug. People were coming to me because they were the early adopters. They were ahead of the game. They felt, I'm going to take on the PrEP stigma in terms of being an early adopter. But now I feel actually it's phase shifted into a normalization approach, which is a lot of people come to me and they say, all my friends are doing it. This is what this is just the accepted norm for things that we do to protect ourselves against HIV. And I feel as that message goes out and it's not stigmatized as saying, oh, you have to have a lot of sex to get onto PrEP, I think there'll be a phase shift. But you have to create demand for the system to start to change.
Thank you. The three of you, thank you very much. So we have a few minutes for questions. I did want to, just if you're feeling like you want to take some action on this, there is a link, youthco.org. If you go to that, if you want, please do it today. That would be great. We're understanding that our advocacy and the pressure is working and that people are hearing the message, and that's being, it's trickling down to decision makers or working its way up to decision makers. The youthco.org petition, it's really easy. You don't have to write the letter yourself. It's a pre-written letter. You just plug in your name. It will send a copy to Minister Dix, and it will also CC your local MLA. You don't need to find out who that is if you don't know. The technology or the software will do that for you. So please, I would encourage you to take a moment. Also, after you send a letter to your local MLA, if you're really feeling passionate about this, meet with them. We've had meetings with Spencer Chandra Herbert, with Sam Sullivan, with the Green Party. We're reaching out across partisan lines to really make the case for this, and I would encourage you all to do the same. Shall we have some questions?
So, Alex, Josh from Health Initiative for Men, and you actually shared this with me, and I want to make sure it doesn't get lost. An important access point for generics is that if you are not a permanent resident or citizen of Canada, you can actually have them mailed to your home address. So this would be students, temporary foreign workers, or somebody on a refugee status. They actually have different rules and can get the generics mailed in.
That's correct. Yeah, it's only Canadian citizens and permanent residents who are not allowed to import medicine to Canada by mail or courier. So if you're like Joshua said, if you're here on a work visa or a student visa, there's the process is described on my website where one can order medication, generic PrEP online and have it shipped directly to your Canadian home address.
And I think just one other quick brief thought around the idea of advocacy and action. It's not an endpoint, it's something we're going to have to keep up. And I actually see the future of PrEP as being greater and greater inequities to access. Damon, David Thompson, and I were all in San Francisco meeting with Gilead this week, and Damon was able to finally pull teeth and get them to say that 145,000 men in the United States are now taking Truvada for PrEP. Of course, it's a much larger population, but what was really remarkable was outside of us, most of the other individuals on this community advisory group are either young queer men of color, women of color, or trans women. And for them, their reality was the communities are not accessing PrEP. And I think if we look at Canada, if we look at Vancouver with a 43% foreign-born population, Mark, all the good work you guys do upstairs, what do we do with a Punjabi-speaking individual who wants to access PrEP? We don't have the resources necessarily to develop these materials, let alone the doctors who are trained. So it's going to be a fight for funding just for that kind of resource development as well to keep trying to level the playing field. But that said, great job for all of you for all you do for PrEP.
Thanks, Josh.
I'm assuming that the legislation that offered some enhanced level of protection to first responders, this may be 3 to 5 years ago, who apparently had not learned about universal precautions vis-a-vis HIV is still in effect. And I think one of you made the comment around public health regulatory approvals, and I think it was vis-a-vis PHAC, not being forthcoming around PrEP, but alluding to the fact that PEP was given that a pass without that, which again to me sounds a bit discriminatory in that I can imagine that people coming in for the day after would be possibly a different demographic than people trying to avoid in the gay male men who have sex with men community. Did I hear that correctly, or did I misunderstand something?
Yeah, I'll try to. So I think you might have been picking up on the comments that I was making about kind of public health writ large. PHAC was one example relevant to that particular issue of us, trying to engage them in our guideline process. But public health writ large, being silent on the issue of PrEP, or not at least showing the leadership that I wish that public health had shown across the country. And that there was a bit of PrEP exceptionalism, for lack of a better term, in that there was this kind of strange stigma, reluctance to engage on that topic. The excuse, the rationale, the explanation that was given was, because there's no regulatory approval for that. And I was just pointing out that isn't an argument that to me holds any water because of the position that other public health authorities have taken across this country on other aspects of harm reduction and PEP. Sometimes. PHAC, to my knowledge, hasn't said anything official about PEP either.
And again, whether I understood you or not, Mark, did you allude to a syphilis prophylaxis as the form of Truvada is for HIV under study?
So that is going to be a question of study. So in France, they have done a study looking at using an antibiotic called doxycycline as PEP for syphilis. So you had a high-risk sexual encounter, and you took doxycycline right afterwards. It was shown to actually have about a 34% reduction in your likelihood of actually catching syphilis in that context. In Los Angeles, they did another study looking at doxycycline as an antibiotic for syphilis PrEP. So here, people took doxycycline on a regular basis prior to their sexual exposure, and that was found to actually reduce other STIs like chlamydia, but didn't have enough people under study to see if it would actually reduce syphilis as well. So what we're looking at is saying, okay, most people who might be at risk for syphilis should be on PrEP. So we're going to offer them, as part of the study, regular Truvada for PrEP, and we're going to then offer them a time period of using doxycycline to see, is it tolerable? Is this something that guys are interested in? Would they have side effects? Is this something that in the future should be evaluated in a larger study as a mechanism to protect people against catching syphilis? So our study is very small. It's really looking at tolerability and acceptability of using doxycycline to protect yourself against catching syphilis based on these other studies that have been done. Yeah, so you did hear me.
I access my medical care at the Kool-Aid Clinic in Victoria, which basically is a very low barrier setting. And my family physician, Chris Fraser, when I became a landed immigrant, I believe, when I got on Medicare, asked me pointedly, was I sexually active? Because we were ordering my quarterly lab reports. When I said yes, he said, well, I think you should be tested routinely for STIs. And I was glad that he took that proaction.
Yes.
And it would be nice if there could be some education around that. If HIV positive men are having their screenings done, let's tack on a general screen for STIs and prevent future problems.
Yeah, you're correct. I mean, the data from the PrEP studies in America show very clearly routine screening every 3 months for sexually active MSM is probably the best intervention you can do to identify asymptomatic STIs. And I think there should be no reason why, which is recommended in the US guidelines, should apply to people who are living with HIV as well. We certainly try and offer people syphilis testing every 3 months, and we should do all full STI testing for people that are sexually active, I must say.
And just a shout out to our friend and colleague Anne Burchell, who's led a trial in Ontario looking at routine syphilis testing in HIV positive guys in Ontario. Just wrapped up the study recently, so the analysis is underway looking at the impact of just doing routine syphilis testing every time someone does their HIV blood work. Make sure that systematically a syphilis test is done, and we'll see what the impact is on diagnosis rates and et cetera.
Thanks, Darrell. Over here.
Recognizing that we still have the problems with, abilities across the border, distance to the border, et cetera. Negating those for a moment, is cost really an issue for PrEP, for importing generic PrEP from overseas, when it's down to about $1.25 a day for the lowest cost provider, if I'm not mistaken? So that's really more just of a comment. Another comment being, I think one group you should try and engage in educating doctors is not just the people who are wanting to access PrEP, but try to engage PAWS men or PAWS people to talk to their providers. They don't have the barrier of potential slut shaming or whatever from their doctor, so that they may have an easier ability to at least get that piece of education started with their physician. And one more small point. Language matters. It gets problematic when we try to sell PrEP by still talking about HIV as a potentially deadly blah, blah, blah disease. It's only potentially deadly if people aren't getting tested. If they aren't getting tested, then we're doing something else wrong. So we have that, and we also need, it is really problematic that we see an awful lot of people still play this game of, okay, somebody's on treatment, they're undetectable, well, they might be lying. That's a really big problem that I see in PrEP circles. And I don't know how we address that. One tiny little last point. This entire conference is talking about combination prevention. We've got, 5 or more speakers on PrEP. We've left discussion of undetectable viral loads to after all the professionals have gone home and stuck it in a community meeting on Saturday that will have far fewer people in it. Is that not a big gap in the combination prevention? Are PAWS people not part of the combination?
I think that question's probably for me, not you guys, but. Did you want me to respond? REU equals U.
If you wish.
I think that was a deliberate choice to hold sessions on Saturday that we thought would be educational and interesting for the broader community. I don't know if you guys feel the same way, but when you look around this room, we're largely healthcare professionals here who are working in the field, and that's not to negate those of you who are community members who came out to support the summit. We want more of that. That's why we're doing the Saturday meeting. However, we didn't have a lot of abstracts around U equals U this year, so we decided to park that particular content on the Saturday when we thought we could have the biggest impact with community members. I'm hoping all the healthcare professionals here aren't just going to go home, though, that you're also going to join us on Saturday. So it's something that we recognize, and certainly including that in the future will be something to consider. Thanks.
Hello. Thank you so much for your information this afternoon. I am new to the PrEP conversation, so apologies for my lack of knowledge, or hopefully not ignorance. Thinking about PrEP as part of that combination prevention, I guess my questions or thoughts to the panel are maybe have you come across anything in the studies that you've either participated in or seen about how taking PrEP may impact other STBBI rates. So looking at behavior change or how that fits into the conversation. yeah, I'm not sure how to phrase that right, but if you have any thoughts, I'd love to hear it. Or is that not a concern, maybe?
It is a concern. Well, not a huge I think there's a lot of ways to approach that. So in some sense, that was evaluated in the initial PrEP studies in terms of IPREX and also PROUD. And they didn't see, when they looked at some of the risk compensation aspects, that people did have a huge change in terms of either statistically significant different rates of STIs or sort of other behavior change. Whether that is true in the real world, I think, is one of the big questions that remains unanswered in terms of PrEP. So if you're starting on PrEP, do you feel so protected by using Truvada that you now decrease your condom use or maybe increase the frequency of partners? I think these are questions that certainly anecdotally people say happen and other people say don't happen, but I think still is out there as one of the questions that has to be evaluated. I think the data from the US PrEP demonstration studies tells us clearly people are having lots of STIs, and part of that is improved diagnosis because you're seeing a provider every 3 months and you're being screened every 3 months, which you may not be doing if you're not on PrEP, where how often you test is really much more sporadic. So I think for sure we will see higher rates, which might be driven purely by improved diagnostics. In fact, I think there are some mathematical models that suggest purely by diagnosing people and treating people early in their asymptomatic course, this might eventually decrease some of the STI rates overall. But I think it is one of the unanswered questions, and I think it's a good one. I don't know, Darrell, if you want to add more to that.
I'll just say a couple of things. I agree with everything Mark said. The data so far in the first kind of generation of trials that proved that PrEP works looked very carefully for this and did not, as a body of literature, did not convincingly show that that happened. At least not to a statistically significant degree. Now, I think common sense, though, tells us, I don't care kind of what those studies showed, common sense to me predicts that that will happen. People will have more sexual partners. We know that people use PrEP for sexual pleasure, and that's not a bad thing. So we simply have to be prepared for it. I'll show you some data tomorrow in from our own PrEP demonstration study about the rates of STIs are very high, and it's of concern. It's part of the thing that's galvanized people like Mark to run this this study looking at syphilis prevention. But we have to ask ourselves: this is a reality? Or it will become a reality, whether it is or it isn't. I should also editorialize and just say, we're launching a big cohort study in Ontario to kind of study kind of more real-world outcomes on PrEP that will launch probably in January. We're hoping to marry it with a small cohort here in Vancouver and in Montreal to get some national data on what happens with PrEP in real life with things like sexual behavior and STIs. But then, predicting that it will happen to some extent, we have to ask ourselves, is this... how are we going to respond? Is it going to be... The problem is that too often that is invoked as a reason that PrEP is bad or something. No, it's a reality. We just have to be prepared for how we're going to respond to it. It's a big challenge, but it's not a reason to throw the baby out with the bathwater.
Absolutely. Thank you.
Rates of STIs are so high already.
Alex, did you want to add anything to that?
I was just going to chime in that that kind of data shows that in those trials that we're reaching the people that we want to reach. That is all.
Great. Well, thank you, gentlemen. So that concludes our formal program for day one of Summit 2017. But we'd like to invite everyone to join us for a networking reception in 1400 to 1430. Grab a glass of wine or a beer or a Perrier and join us for some informal chats. I know Mark has to get back to work, but I think Darrell and Alex will probably stick around. I also just wanted to say I recognize that today was PrEP heavy. Definitely, and thank you for that comment. I think you'll find tomorrow, while there's still lots of PrEP content in the program, we're actually going to close with a plenary on mental health and combination prevention, and that's setting us up for next year, thinking ahead to the types of topics that we want abstracts to come in around next year, and that's going to be a focus on mental health and substance use. So we recognize that PrEP is not the only part of combination prevention. So thank you, everyone.